Good evening, all. Today, our presenter is Dr. Anju, and our chairperson is Dr. Rekha. I welcome Dr. Sahasraman sir and all other students, PGs, and faculty members to this presentation. Okay, we can start now. Anju, you can present now.
Elizabeth, for people who do not know, Anju, everything Alana, who is Rekha, okay, for the information of all.
Okay, sir. Anju is from Assisi Medical College, and Rekha is our own alumni. She was my senior, now working as a faculty in Manjeri Medical College. Anju, is it okay now? Can we start?
Oh, no. Yes, ma'am.
You can share now. You have been made the host, so you can share.
ഇതിനകത്ത് പോയിട്ട് പവർ ഓപ്പൺ ചെയ്തിട്ടുള്ള ടേബിൾ ഇല്ലേ, അവിടെ നിന്നാണ് സൂമിലോട്ട് കണക്ട് ചെയ്യേണ്ടതെന്ന് തോന്നുന്നു. പവർ പോയിന്റ് എടുക്കുക.
PPT തുറന്നിട്ടുണ്ടോ? അഞ്ചുവിന്റെ PPT ഓപ്പൺ ആണല്ലോ അല്ലേ? ബാക്ക്ഗ്രൗണ്ടിൽ PPT ഓപ്പൺ ആണല്ലോ.
Yes, sir.
പവർ പോയിന്റ് എടുക്കാതെ
ഷെയർ ചെയ്താ വരണം.
ഷെയർ ചെയ്യും.
എന്താ വരുന്നത്? Not able to share.
Anju, keep your cool, no problem. Anju's face ഭയങ്കര tense ആണ്.
Tensed ആയിട്ടിരിക്കുന്നു.
No reason to be tense at all. No. Be cool.
PPT ഓപ്പൺ ചെയ്തോ അഞ്ജു? Yes, ma'am. അപ്പൊ അതില് സ്റ്റാർട്ട് ഷെയറിംഗ് എന്നിട്ടൊരു
എലിസബത്തിന് എലിസബത്ത് ഷെയർ ചെയ്യുന്നോ?
ഡോക്ടർ അജു, ആ താഴെ ആ സൂമിലാണ് ഷെയർ ചെയ്യേണ്ടത്. സൂമിൽ ആ പാർട്ടിസിപ്പൻസ് ചാറ്റ് അങ്ങനെയൊക്കെ ഉള്ളതിൽ ഒരു ഷെയർ എന്ന് പറഞ്ഞൊരു ബട്ടൺ ഉണ്ട്. പവർ പോയിന്റിലല്ല, സൂമിന്റെ അതിന്റെ ഉണ്ടല്ലോ.
സൂമിന്റെ താഴെ ഷെയർ സ്ക്രീൻ എന്ന് പറഞ്ഞിട്ട്
ഷെയർ എന്ന് പറഞ്ഞൊരു ബട്ടൺ ഉണ്ട്. ഒന്ന് നോക്കുക. പാർട്ടിസിപ്പൻസ് എന്നൊക്കെ ഇല്ലേ, പാർട്ടിസിപ്പൻസ് ചാറ്റ് മ്യൂട്ട് ആ ബട്ടൺ ഒക്കെ ഉണ്ടല്ലോ. മ്യൂട്ട് സ്റ്റാർട്ട് അതിന്റെ കുറച്ചുകൂടെ റൈറ്റ് സൈഡിൽ ഷെയർ എന്നൊരു ഇത് കാണുന്നില്ലേ? താഴെ ആ മ്യൂട്ട് സ്റ്റാർട്ട് വീഡിയോ ഒക്കെ കണ്ടില്ലേ ബട്ടൺ, അതിന്റെ റൈറ്റിലോട്ടായിട്ട് വേറെ ഏതൊക്കെയാണുള്ള?
ഇപ്പൊ സൂമിന്റെ സ്ക്രീനിലല്ലേ നിക്കണേ ഇപ്പൊ? അതിന് താഴെ ഒരു റോ ഓഫ് കാര്യങ്ങളുണ്ടല്ലോ. നമ്മള് മ്യൂട്ട് വീഡിയോ ഒക്കെ. യെസ്.
ഓക്കെ.
Okay, now you can present.
Aliar Kunju, 69-year-old male, is a businessman residing in Kolapada. Presenting complaints: diminution of vision, left eye for 7 months, pain and redness in left eye for 2 weeks. History of presenting illness: the patient was apparently normal 7 months back, and he developed insidious onset of defective vision, which was gradually progressive in nature in left eye. And he consulted nearby eye hospital, and IOP was found to be high in left eye. and given topical anti-glaucoma medications 2 times daily. 2 months back, he is hospitalized for urinary incontinence, and since then, he is in regular topical medication. 2 weeks back, he is presented with sudden painful loss of vision along with the redness in our OPD, of left eye in our OPD. We started topical and oral anti-glaucoma medications. There was no history of vomiting, colored halos, or photophobia, no history of ocular trauma. 1 week back, one sitting of laser treatment was done in left eye. Now the patient came for review. Past history is a known case of coronary artery disease for 7 years and on antiplatelets. Systemic hypertension and dyslipidemia for past 3 years and on oral antihypertensive and statins. Diabetes mellitus for past 5 months and on OHA under glycemic control. No history of bronchial asthma, no history of ocular surgeries in the past. Family history, there was no relevant family history. Personal history, take non-vegetarian diet, normal sleep and appetite, normal bowel and bladder habits, and no additions. General examination, 69-year-old male who is conscious, cooperative, well-oriented to time, place, and person, who is moderately built and nourished. There was no pallor, icterus, cyanosis, clumping, lymphadenopathy, and pedal edema. Vitals, BP 130/80 mmHg in right upper arm in supine position. Pulse rate 78 per minute, regular in rate, rhythm, and normal in volume. Bilateral carotid pulsation felt equally no brood. Temperature afebrile. Pulse rate 20 per minute, abdominothoracic. System examination, respiratory system, normal vesicular blood sounds heard bilaterally, no added sounds. Cardiovascular system, S1, S2 heard, no murmur. Central nervous system, higher mental function with a normal limit, no focal neurological deficit. In GAT, paradigm soft, non-tender, and no organomegaly. Ocular examination, head posture normal, no facial asymmetry, orthophoric, ocular movements, both adductions normal, vergence normal, and versions normal. Confrontation test normal in right eye, cannot be assessed in left eye. Distant uncorrected visual, since the affected eye is left eye, so I started with left eye. Distant uncorrected visual acuity of left eye is hand movements and peer accurate. Vision with pinhole, not improved with pinhole. Near vision less than N36 with add 3 diopter. Color vision cannot be assessed. Lid and adnexa normal, conjunctiva normal, no conjunctival congestion or ciliary congestion. Cornea normal in size and shape. Diffuse epithelial and stromal edema present. No pigments or pseudoexfoliated deposits seen on the endothelium. No keratoprecipitate precipitate present. Corneal sensation normal. Anterior chamber Van Harris grade 1. No cells of flare. Pupils central in position, round, size 5 mm, pharmacologically dilated. Pupils not reactive, near reflex absent. Lens, nuclear sclerosis grade 3. Anterior vitreous face, no hazy view. Fundus examination with a distant direct ophthalmoscopy, red glow present. Media opacity present. Fundus examination done using slit term biomicroscopy and 90-day lens. And periphery examined using indirect ophthalmoscopy and 20-day lens. Hazy view due to lens opacity and corneal edema. Disc hazily seen. Some abnormal vessels seen on the superior-temporal quadrant of the disc, probably NVD. Neovascularization of disc. Few PRP marks hazily seen in the posterior pole. Further details hazily seen. Intraocular pressure monitored with applanation tonometry on 24th to 2024 at 11:30 a.m. is 42 mmHg. On corneoscopy with Coleman 2-mirror corneoscopy, closed angle, no structures visible in superior, medial and lateral quadrant. Shabby line visible in inferior quadrant. Unless image of right hand. Summary: 69-year-old. So right eye examination, distant uncorrected visual acuity is 6/36. Vision with pinhole is 6/9. Near vision N10 with add 3 diopter. Color vision normal. Lid and adnexa normal. Conjunctiva normal, no congestion. Cornea clear. Normal in size and shape. No epithelial or stromal edema present. No pigment or pseudoexfoliated deposit on the endothelium. No KPS. Corneal sensation normal. Anterior chamber Van Harens grade 4. No cells of flare. Iris normal color and pattern. Pupil central in position, round 3 mm. Direct reflex pleasant, concessional reflex absent, near reflex, concessional reflex absent, near reflex plus. Lens nucleus sclerosis grade 3, anti-vitreous face, no cells of flare. Fundus examination with a distant direct ophthalmoscopy, red globe present. Media opacity along with the movement of the eye. Fundus examination of the right eye, hazy view due to lens opacity, vertically oval average size disc with margins well defined. Cup disc ratio 0.3, NRR pink, no notching, ISND rule followed. No disc hemorrhage, no peripapillary atrophy, no bearing of the circumciliary vessels or nasalization of the vessels. No lamellar dot sign, no RNFL wedge defect present. Arteriovenous ratio 2:3. No AV crossing changes present. Macula FR absent. Periphery up to oris aorta normal. Intraocular pressure monitoring with applanation tonometry on 24th to 2024 at 11:30 a.m. Stitch 16 mmHg. Gonioscopy with Goldman two-mirror gonioscopy. Open angle up to sclerus pleuris visible in all quadrant. Summary, 69-year-old male who is a known case of coronary artery disease, hypertension, dyslipidemia, diabetes mellitus, presented with complaints of diminution of vision left eye for 7 months and sudden onset of defective vision associated with the redness and pain in left eye for 2 weeks. On examination, best corrected visual acuity was 6/9 in right eye, hand movements plus in left eye. On left eye, diffuse epithelial and stromal edema present. Neovascularization of the iris seen 360-degree in iris around the pupillary margin. Lens shows nucleus sclerosis grade 3 cataract. In fundus examination, disc hazily seen. Some abnormal vessels in the superior temporal quadrant of the disc is seen, hazily seen, which is probably neovascularization of the disc. And IOP measured with applanation tonometry was 42 mmHg. Gonioscopy shows closed angles. On right eye, anti-segment examination normal. Nucleus sclerosis grade 3 cataract. IOP with applanation tonometry was 16 mmHg. Open angles on gonioscopy. Fundus shows hazy view and CDS 0.3. Visualized retina within normal limit. No evidence of diabetic and hypertensive retinopathy seen. Diagnosis, neovascular glaucoma, left eye, angle closure stitch, probably secondary to central retinal vein occlusion, immature senile cataract both eye, coronary artery disease, systemic hypertension, dyslipidemia, and type 2 diabetes mellitus.
Okay. So Aparna, can you just summarize the history? Now your diagnosis is neovascular glaucoma, secondary to CRVO. So can you summarize the history? What was the series of events that had occurred? And can you correlate with the diagnosis?
Yes,
Patient
ma'am.
presented
Patient presented with a diminution of vision left eye for 7 months. Patient had a history of diminution of vision left eye for 7 months, which was insidious in onset. And he's at that time he consulted nearby eye hospital, and at the time IOP was monitoring. It was found to be very high and give topical medications as per patient. Then the patient patient is admitted in Trivandrum Medical College for urinary incontinence 2 weeks back, and he is not on a regular medication since then. And he had 3 days back, and he had after that he had pain and redness in left eye.
Sudden, okay, sir, severe pain since last 2 weeks, isn't it? Last 2 weeks he had pain. So, usually the history will be in CRVO. What is the type of defective vision? Usually it is?
Sudden diminution.
Okay, so this history, how can you correlate with the diagnosis? So what may be the events that had occurred? So he didn't complain of any sudden onset defective vision. It was an insidious onset of defective vision, isn't it?
It was insidious onset.
So what may be the reason? So how can you come to the diagnosis of CRVO? Like, okay, now you can just start your clinical examination, ocular examination. You can just share. Okay. So visual acuity, here I just want to ask one thing. In the right eye, vision was improving to 6/9 with pinhole. Near vision was N10 with +3 diopter lens. What does it indicate? Patient is having nuclear sclerosis, but usually with
Grade
+3
3.
lens. Yeah, grade 3 nuclear sclerosis. Okay, but with distant vision is improving to 6/9. So if near
Sense,
vision is affected, what may be the reason for that? Usually we should suspect some macular pathology, isn't it? In the other eye. Okay, that's the right eye. Okay, left eye, okay, the vision is hand movements. Okay, next slide. Okay, so a neovascularization was seen in the pupillar area, isn't it? So, okay, so what are the conditions? So when you see NVI, what all conditions come to your mind? Like what are the differential diagnoses of rubiosis?
Rubiosis, diabetic retinopathy, proliferative diabetic
Yes.
retinopathy.
Okay.
Then
CRVO in this
then
case, isn't it? This case it is CRVO. Hello?
Anju?
Seems to have some connectivity issues.
Where PG's Aishwarya PG anallala. We cannot identify. Aishwarya Aparna ana. So what are the conditions that causes rubiosis iridis? One is diabetic retinopathy. Aishwarya, are you there? Aishwarya?
Anshu, now you are
Yes.
muted. Anshu is muted.
Okay. Okay, Anju. What are the conditions that cause rubiosis iridis? One, as you told, is diabetic retinopathy. Then
central retinal
what is
artery
the case?
occlusion.
Central retinal vein occlusion, as in this case,
yes.
Isn't it? Artery occlusion, it's the possibility is only less because why?
Then ocular ischemic syndrome.
Yes. Next comes ocular ischemic syndrome. Then any other?
Ocular.
Chronic inflammations also you should keep in mind.
Chronic
These are the-
uveitis. Then the conditions like sympathetic ophthalmia, weakage. Then it may
Okay,
be
so
due to
these four are the common conditions, isn't it? Diabetic retinopathy, CRVO, ocular ischemic syndrome, and chronic inflammation. There are many other conditions. Okay. Then, okay, slide share poila. Okay, then next was your, and you have written anterior chamber, no cells and flare. So there was
Yes,
so
ma'am.
much of edema that you are not able to see the fundus. In such a cases, we may not be able to comment upon the cells and flare. Okay.
Okay.
Isn't it? You have written no cells and flare. So much of edema, you are not able to see the fundus. So in such a case, it is difficult to comment about the cells and flare. Okay. Then what was the 1 or 2 points I wanted to the presentation. Okay. So okay. In gonioscopy, okay, gonioscopy it was closed angles.
Yes, ma'am.
So now in gonioscopy, it's better to write instead of writing numbers, it is better to write the structure that is seen. Okay, if you are able to see the Schwal baseline, you can write Schwal baseline in that quadrant. So that is the way you have to write now in gonioscopy.
Yes.
And if you are writing like this, you have to tell what is the grading also, grading system that you are using. I think you didn't
Shafi's
mention
grading
about the
system.
grading system. Okay.
Shafi's grading.
Then One more point. Fundus examination, it was hazy and there was a doubtful. Some vessels were there on the
Some
test.
vessels on the,
Any other possibility other than NVD?
maybe collaterals.
Okay. What do you mean by collaterals? Is it how would you differentiate between collaterals and optic disc?
Collaterals are the
NVD.
vessels which is collaterals are the vessels which is seen in the pre-existing capillary architecture. There was, and which can connecting the occluded vein to non-occluded part. In neovascularization, there is a
Okay.
new vessel formation, and it is commonly seen near the ischemic areas. And
Okay, these are leaky vessels, it's neovascularization, but this collateral usually don't leak. And what are opticociliary shunt vessels means? Is there any specific thing? Opticociliary shunt vessels
yes, ma'am, it is seen in
usually
case of
connects with the central.
it is choroidal circulation, retinal circulation, choroidal circulation. It is mainly seen in case of optic nerve glioma, sheath glioma.
Meningioma, and also in CRV also you can see. Since the vein is obstructed, it is getting the veins are getting connected to the ciliary choroidal circulation. Okay. So now your diagnosis is neovascular glaucoma. What is the stage of the disease?
Stage is angle closure stage.
Okay, secondary to CRVO. Why did you tell it to secondary to CRVO?
Ma'am, after the first event, this become occurs after 7 months. A second episode is occur, and this patient CRV is also known as CRV can cause 90th day glaucoma. Then neovascularization glaucoma is also known as 90th day glaucoma, and the patient had history of hypertension, CAD, and the patient has diabetes mellitus for last 5 months, and other eye examination is also normal. And CRV is also a most common cause for neovascular glaucoma.
But here he didn't give any history of sudden onset defectivation, isn't it?
Yes.
So one possibility we think of is maybe the patient had a non-ischemic CRVO initially.
Yes.
And then there was some macular edema which may be progressing. So that may be the cause of progressive defectivation along with the progression of cataract. And then what is the rate of non-ischemic CRVO can lead on to ischemic CRVO? How many percentage of non-ischemic CRVO can lead on move to ischemic CRVO?
1/3 case.
Okay,
Cases.
over 1 or 2 years, 1/3 of cases can
2 years, over 2 years.
Okay, so okay, so that may be the cause. Usually such cases, these patients will present with sudden onset defectivation. So here he didn't present like that. That is why I'm asking. Okay, so how will you differentiate between a normal iris vessel and a neovascularization of iris? What are the differences?
Normal neovascularization, normal iris vessels is present in the stroma, and new vessel is seen on the pupillary margin, around the pupillary margin. And new vessel is irregular in arrangement, and normal vessel is regular in arrangement. And new vessel is fenestrated, and normal vessel is not fenestrated. And the new vessel which can cross the scleral spur, but this iris vessel doesn't crosses the scleral spur. And move to the histology, there's endothelial tube only in the new vessel, and all codes are present in the iris vessel. And iris vessel leak on effect, fluorescent angiography.
Yes, fluorescent angiogram, it will leak. Okay, so any differential diagnosis for your case?
We do to ocular ischemic syndrome. The patient, since the patient had coronary artery disease for a long duration.
Coronary artery disease is there. So one possibility is ocular. So that is why in your examination you have written carotid pulse, isn't it? Both eyes it is normal. Both sides it is not. Okay.
Both.
That any other possibility? Any acute angle closure attack can also present the same way. And how do you differentiate if it is due to acute angle closure attack? I mean, what is the difference? Why did you tell it's not a acute angle closure attack in this case?
An acute closure attack, there was
What about the other eye?
the other way I was normal.
Other eye is normal. There was no Van Herx was grade 4, isn't it? And angles were open. So it's a secondary angle closure type of glaucoma.
Glaucoma.
What are the so what is the reason for angle closure in this case, neovascular glaucoma?
It is due to the contraction of fibrovascular membrane in the angle.
Okay. There is a fibrovascular membrane. If it contracts, it goes down to angle closure stage. Okay. So now what are the so you in your fundus examination you have seen the neovascularization and some PRP marks, isn't it? Okay. So how will you investigate this case?
First, I want to know the metabolic control of the patient. So I started with FBS, PPBS, and HbA1c, and total lipid profile, and this check the BP. Then I complete cardiology investigation, including ECG and echo. Then
So what cardiology? Why did you do cardiology evaluation?
No, ECG and echo. Since the patient has CAD history.
Okay.
Then OCT and FA, since the patient has hazy view, so then I do a B scan
that is
to
not possible.
find out any traction.
You have done a gonioscopy with a what is Goldman's lens, isn't it?
Goldman's
and you have understood that is a closed angle. So, how do you know whether it is a cynical angle closure or it's a positional angle closure?
So by indentation gonioscopy, the cynical angle closure does not open. By doing indentation.
Okay.
Indentation
So, I mean, which type of lens is used to do indentation gonioscopy? Can you do with the Goldman lens?
No, ma'am.
Why can't you do with your, why?
There was concavity, and the lens becomes smaller than the cornea, so that
the curve. We should press over the cornea. La. What is the what do you mean by indentation? What do you mean by indentation gonioscopy?
While pressing the center of the cornea with the lens, then the angle becomes.
You are pushing the aqueous. Aqueous. So if there is a cynical angle closure, it remains like that. If it is appositional, it will open. And what do you mean by manipulated gonioscopy?
Manipulated gonioscopy, you ask the patient to look on. Look on this side.
Towards the mirror, isn't it? Look towards the mirror, and sometimes it can open up. Okay, so that is manipulative gonioscopy. So these are the two types of gonioscopy. Now, you have done applanation tonometry. There is so much of corneal edema. So, will there be any change in the value of the intraocular pressure? How was it? If you measure applanation tonometry in a patient with corneal edema.
Yes, ma'am, because the corneal thickness, which is
what happens? So in a patient with corneal edema, usually the intraocular pressure is underestimated. What happens if the cornea is thicker? What happens to the intraocular pressure in a thicker cornea?
It become less.
Thicker cornea, this will be false positive result.
False
Falsely
positive.
high. And thinner cornea, lesser. Okay, false low value will be C. Okay, so in your investigations, you did all your blood routine, diabetic workup, hypertension. So what is the purpose of doing this investigation?
And to find out the patient is on good control or not, and to starting the medication, for starting the medications.
Not only to start medication, because other eye is also at risk, isn't it? He is having all the comorbidities, so other eye is also at risk. We have to control all the risk factors. Okay, so FFA, what is the purpose? Here it is difficult to do FFA because it is hazy media. So what is the purpose of doing FFA?
Just find out whether this vessels is leaking. Or to,
okay, if there is any areas of other than what we have seen, any other areas of neovascularization, then also to see the amount of capillary. What areas? Capillary? Non-perfusion areas. Non-perfusion areas we can see. Okay. Then suppose this patient is having all the comorbidities. Suppose it is a younger patient with no comorbidities like diabetes, hypertension. Any other investigation you would like to do?
I would
with the CRVO, patient with the CRVO.
Okay. Blood means try to rule out protein S, protein C.
Hyperviscosity syndrome, coagulation profile. All these things should be done. Okay. You know the cause for CRVO. Okay. Now, so what have you done for this patient?
Moving to the treatment. The patient has IOP is more than 40 mmHg. So I started with the IV mannitol. IV mannitol 20%, IV 100 ml of 20% IV mannitol in a dose of 2 gram per kg over 20 to 30 minutes. Then after knowing the history of after checking any sulfur drug allergy, I start tab acetazolamide 250 mg BD. Then give topical anti-glaucoma medications. Then cycloplegics like atropine eye ointment 1% BD.
Which topical anti-glaucoma medication did you start?
I will start with carbonium anhydrase. Because prostaglandin is contraindicated and beta blockers, since the patient has cardiac risk, so beta blockers is contraindicated.
Then, so now we have lowered the intraocular pressure. Is that the only thing that we have to do? Any other? So what are the different strategies that you have to take? One is to lower the intraocular pressure. Next is?
Next is symptomatic point to reducing the pain. So I give cycloplegics, and to reducing the inflammation, this steroids like prednisolone 1%, eye drops will be given. Then
okay, so cycloplegics and anti-inflammatory can be done for symptomatic relief. Yes.
Then after fundus view, I give PRP.
Okay.
Then
so we hope that the corneal edema will decrease, isn't it? Corneal edema decreases and we have a better view. Okay. So you'll give a PRP. So and how will you give PRP in this patient? What is it? How many spots? How many spots in each sitting? With how many sittings?
The three setting. Spot size is 500 micrometer spot size with 0.1 second. And
like, is there any? Is it the same way as diabetic retinopathy, or is it something different? Anything? Any differences there? Same, but here we need a more intense
extensive.
Okay.
Yeah.
Yeah, because we have to, usually in diabetic retinopathy, we give up to the equator. So here,
equator, more
here we
peripherally.
can more peripherally, and sometimes we may have to give more than one, like lesser than one burn width part, like half burn width apart, we may have to give more number of spots. How many shots will you give in each sitting?
Total 1,200 to 1,600.
Okay, around 1,600 we have to give in each sitting. Okay, so intense PRP. Then, so PRP, how much time will it take for the PRP for the new vessels to regress?
1 week.
Usually it takes 4 to 6 weeks. 4 weeks minimum it will take. So by that time, can we do any other treatment?
For intravitreal anti-VEGF injections.
Yes, intravitreal anti-VEGF. So nowadays, combined therapy is more preferred. We can give intravitreal anti-VEGF also. So during this period, the anti-VEGF also can act. Yes. Okay, so that's about the retinal ischemia part. But here already the angles are closed by cynical angle closure. So any other, will it be controlled by topical medications alone?
No, ma'am.
You can see the patient whether it is decreasing, but usually the intraocular pressure may not get controlled. So what is the next step?
Diode photocoagulation.
Okay, cyclophotocoagulation can be done. But better than that, if the vision is improving, what surgical method will you prefer?
Trabeculotomy. But since the patient has neovascularization and there was less failure chances very high in this patient.
So normal trabeculectomy, the usual trabeculectomy, failure chances very high because there is more of inflammation, there is chance of blood failure. So any other technique, will you want to modify the trabeculectomy? What is modified trabeculectomy? I would like to ask other PGs, but I don't know which are the other PGs here.
Any PG can volunteer.
So what is modified trabeculectomy? Pardon, sir?
I was telling any PG can volunteer. If we do not
but
know who are all the PGs, no. Any PG can volunteer.
Nobody is volunteering. So yes, Kanju itself. Any other? What is modified trabeculectomy? Okay, somebody else? Okay, Anju, you can tell. Nobody is helping you. Okay, you can use other antimetabolites like mitomycin and 5-fluorouracil, isn't it? Along with trabeculectomy. 5-fluorouracil, so that more chance of to decrease the chance of failure.
Formation.
Okay, any other? What other surgical procedure is preferred in NVG? Any other device?
Cyclocryotherapy.
That is all for if there is no vision. So here, the patient is having hand movements vision, but we are hoping that by reducing the intraocular pressure, the vision may improve.
Filtrations with Ahmed wall.
Yeah, so glaucoma drainage devices. So
Devices.
glaucoma drainage devices will be better in these type of patients. Okay. But what is the problem with GDD in neovascular glaucoma? Any other third year PGs? So what are the problems with neovascular glaucoma? There will be new vessels, iris neovascularization will be there. So what happens when there is a drainage
bleeding.
device there? Yes. Who was that? Engineer.
Yes, ma'am.
Okay. So there is high chance of hyphema.
Yes.
Hyphema. Okay. Okay. So glaucoma drainage devices will be better. So nowadays we are clubbing anti-VEGF also with glaucoma drainage device. Initially we give anti-VEGF. So once the new vessels regress, within 1 or 2 weeks there'll be some change, and then we'll go on to glaucoma drainage devices. So, what I hope you understood what are the ways of managing. One is to decrease the intraocular pressure. Okay, we can give mannitol or carbonic anhydrase inhibitors and topical medications. Then we have to decrease the inflammation, as you told. Okay. Then most important is to decrease the amount of retinal ischemia so that more new vessels don't appear. So that part we have to do with the PRP. But here, suppose it is a hazy media. Okay, so we are not able to do a PRP. Then what will you do?
And cyclocryotherapy.
Cyclocryotherapy is
Or
only for,
diode photocoagulation.
okay, so you can have a
Cyclophotocoagulation.
cyclophotocoagulation. Nowadays, so what is the problem with cyclophotocoagulation? Sometimes
which can
the response cannot be sometimes predicted. Sometimes it can lead on to hypotonia and phthisis bulbi. So newer modality is a subcyclophotocoagulation. Have you heard of that? What is the laser used? Which type of laser is used?
NDR.
Diode laser. Diode laser is used. Okay, diode laser. With diode laser, you can give a lesser intense burns. I mean, laser is applied so that the ciliary epithelium is not damaged. It will stimulate it, and also UV scleral outflow also can be increased. So subcyclophotocoagulation is okay. And also we can give anti-VEGF injections even if the media is hazy. Then if the vision is not at all improving, then what will you do?
And then cyclocryotherapy.
There is no visual potential, but pain is also present. In such case, we can go for cyclodestructive procedures like cyclocryotherapy.
Then also.
Sir, Sahasram sir?
So Anshu, one thing, no, you can when you present, no, you can be your speed can be a bit lesser. So otherwise, no. Most of the things which you know before we grasp one thing, you will be on to the next thing. So that's one thing. Another thing, no, the first question of your guru today was, how do you correlate the patient's history with your clinical diagnosis? No, I think your answer was not that appropriate. Because so and this patient, because when you ask the history, you know, some patients come with come out with a very good history, and some the history may be vague. So if you ask them again, no, depending on the diagnosis, if you remodify your questions, you know, the patient will come out with better answers. In this patient, the patient had 7 months duration defective vision, which you said was insidious. So if it was already the patient has got some cataract. The other eye also the vision is 636, and near vision also is poor even with glass. Maybe the patient has got a bit more cataract in this eye. I do not know. So maybe the patient was having defective vision even otherwise. The patient may not have detected that he had the defective vision due to CRPO. So if you ask again, no, maybe the patient may say that he had a rather sort of sudden loss of vision, or it could be like what the Guru told today, that maybe it was a non-ischemic CRVO if the thing is insidious, which later turned and ischemic. So probably, the patient had NCRVO of defective vision few months back, and now the patient developed NVG. That would probably what might have happened, the natural course. And you said that patient went to the local hospital and started glaucoma. The other eye, other eye has no in between I missed something. So left eye, the other eye, no, right eye.
Otherwise,
Right eye IOP is normal, no glaucoma. Or right eye
Yes.
also got glaucoma.
No, sir.
No,
Right
normal,
it's
sir.
normal.
Okay. So
Normal.
so glaucoma is not the cause of the CRPO. So
Yes.
the anti-glaucoma medications might have been started probably recently, not 7 months back. You said patient went to the defective vision to the local hospital 7 months back, and they had started anti-glaucoma medications. So here again, if you ask again, probably after 7 months, if the patient had glaucoma that 7 months back, it's probably that was getting medically controlled since 7 months, now becoming painful. So the history should have been a bit more clear. So and when the first question in an Viva session, the first question with which the teacher asks, if you answer well, you will also become more comfortable, and the examiners will also think that yes, you are a good candidate, and that's a stepping stone. And also, I think regarding the young CRBO causes, which you said no, I don't think you said homocysteine. There are a batch of
homocysteine.
investigations. Homocysteine, I think you didn't tell, did you?
Yes. No, sir. No, sir.
No. Is it important?
Yes, sir.
Yes. So and yes, and that's all I can think now. And for the other club, Mini Poyo. Mini Matthew was there. Susan Thomas Arana.
Sir, our HOD, sir.
Oh, Susan, no. Oh, shit.
Yes, sir.
Susan Thomasനെയാണോ അറിയാൻ
അതന്നെയാണോ?
വേണ്ടിയിട്ടാണ് Susan Thomasനെയാണോ അറിയാൻ വേണ്ടിയിട്ടാണ് വിളിച്ചത്. Susane കാണാൻ വയ്യാത്ത.
Anju, what is the slit lamp settings that you will? Okay, madam.
Susan Thomas, recently only I joined there.
Okay.
Anju,
and also
for
another thing, Anju,
yes.
when the causes of CRP also, I think sorry, causes of NVG ചോദിക്കുമ്പോഴത്തേക്ക് there should be no faltering. At least 4 causes should be in the tip of your tongue. All these 3 causes. Other than that, if some may ask any other causes, then you can say ocular tumors, ocular radiation, various blood dyscrasias producing. So other things will be there. These 3-4 causes. And another thing you said that another name of NVG is 90th day glaucoma. So this 90th day glaucoma or 100th day glaucoma is not the synonym of NVG. NVG can be due to any reasons, but NVG, if it is due to CRV alone, you call it or it manifests as the 90th day, 100th day glaucoma. The other causes do not. So it's not the NVG is not synonymous with 90th day or 100th day glaucoma. Okay, Rekha.
Yes, sir. A differential diagnosis, you can also include inflammatory glaucoma. Okay, if you want me, What are the at least 3 differential diagnoses you can have in your mind? And what are the slit lamp settings that you will do to see neovascularization of iris? In what is it? I mean, is it high magnification, low magnification, or how was it seen? Neovascularization of iris. Initially, it may be seen just as a red tinge or the pupillary
Yes.
area, isn't it? So
Yes,
it should be seen in the
high magnification.
high magnification. Okay, high magnification illumination. And what about Van Harris grading? What is the slit lamp settings?
Oh, one has grading. Put the slit.
So the peripheral anterior
And
comparing it. No.
anterior chamber depth, peripheral anterior chamber depth with corneal thickness.
Corneal thickness. So the angle should be 60 degree. The slit lamp
60.
angle should be 60 degree
Slit
at
lamp.
medium magnification. Okay. So any CRVO case, our aim is to prevent NVG, isn't it? Any CRVO
Yes.
case and proliferated diabetic retinopathy, our aim is to prevent this NVG in this stage. So how will you follow up a patient with CRVO or proliferated diabetic retinopathy? In each visit, what all things will you look for?
And each visit there was we follow up for CRVO case 1 month till 1 month interval till 6 months and 3 month interval up to 2 years.
You know, what all things will you look for in each visit?
Such a visit there was an neovascularization of iris, NVA.
Okay.
Then IOP intraocular pressure.
Okay.
Then a fundus examination.
And in some cases, especially in CRVO, NVA can occur first. Usually,
neovascularization of the angle.
Usually first NVA occurs and later on NVA, but in some cases NVA can occur. So at frequent intervals, we may have to do gonioscopy also.
Gonioscopy.
Okay, then dilate and see what are things you will see in dilated fundus examination.
Look for any neovascularization, any
the disc or
hemorrhage.
any elsewhere, isn't it? Neovascularization of lungs. Okay. Then in ocular ischemic syndrome, if it is the cause for neovascularization, I mean NVG, what about the
Yes.
intraocular pressure? Any difference?
The intraocular pressure was
Even though there is neovascular glaucoma, the intraocular pressure may not be very high in
high
ocular ischemic
in
syndrome.
ocular
Why?
ischemic syndrome.
Why?
Because perfusion pressure.
Yes, there is lesser perfusion, so the ciliary body is also less perfused. So aqueous production itself may be very low.
Yes.
So in this patient, what is your plan now?
Now yeah.
Already one sitting PRP is done. But IOP, IOP, is it the IOP at the time of admission or?
IOP is no ma'am.
Or now after PRP? After PRP. Okay, so what is your plan? So even with topical medications, the IOP is not getting decreased. Is it like that, or is it at the time of admission?
IOP is still.
IOP is still high. Even with glaucoma, anti-glaucoma medications, it is not getting relieved. Okay, so the next step will be to?
Next step, planning for next setting PRP once.
Sir, okay, sir, then we'll. Sahasranaman, sir. Oh, yeah. Chedula. Okay. Okay, so we can give we have to decrease intraocular pressure by giving mannitol and then we can give anti-VEGF injections.
Injections.
Anti-VEGF injections can be given and see whether the media is getting clear.
Clear.
If it is getting clear, we can continue with PRP. Suppose there is a dense cataract that is fundus is not visible. So then what will you do regarding the management?
Do cataract surgery.
So that again can be preceded by anti-VEGF injection. Then we can do cataract surgery. And suppose there is a vitreous hemorrhage due to CRVO or the new vessel bleed that is causing a vitreous hemorrhage. Then how will you proceed? We are not able to see the fundus.
Give anti-VEGF.
You can give anti-VEGF, and if it is not getting clear, you may have to do a Paathsaala vitrectomy and
Vitrectomy.
endovascular. Any others who would like to ask questions? Okay. So, Susan madam, അടുത്തിന് ഓർമ്മ ഉണ്ടോന്ന് അറിയില്ല. Okay. So, Elizabeth, then
Yes, Rekha. Can we wind
I
up?
think it's, yes, sir. Yes, Elizabeth, then we can.
Okay. Okay, we can wind up. Anju, even though you are tense.
ഞാൻ ലീവ് ചെയ്തെന്ന് പറഞ്ഞു, ലീവ് ചെയ്തില്ലായിരുന്നു രേഖ.
Sorry,
നല്ല ഡിസ്കഷൻ ആയിരുന്നു. And also best wishes to എല്ലാവർക്കും best wishes. Okay.
Thank you, sir. Thank you.
Good night, sir. Good night, sir. Anshu, even though you were seen little tense at the beginning, but you presented well. It's just it's not an exam. It's just a presentation only. So carry on. You can make it better, even better next time. And thank you, Rekha, for sharing this presentation. And I express my sincere thanks to you for taking this opportunity, and I'm expecting more like this from you, and I am expressing my gratitude and thanks to all those presented here for this presentation. And we will be meeting for the next presentation the first week of next month. Okay, thank you.
Okay, thank you, Elizabeth, for giving me this opportunity.
Okay, thank you, Rekha, for covering.
Thank you, madam.
Okay.
Ma'am, can you please open your video?
My God. Okay.
Madam.
Thanks everyone for support. Okay.
Okay, madam. Okay, madam. Bye. Thank you.